Hello, good evening. I'm Dr. Janice Morrow with American Mood Swings, and tonight we have Dr. Faried Banimahd from the American Addiction Institute of Mind Medicine here in Irvine, California. So he is an addiction specialist and he has a background in ER medicine, and we're very grateful that he's here tonight. Let's talk about now how somebody calls you up. Hey, I want to quit opiates. I'm strung out. I need to quit. And they come into your office, and let's go from there. How are you going to determine the course of action, and what is treatment involved? And let's go into like the acute withdrawal, chronic withdrawal, and the different medicines and that kind of thing.
Are you talking strictly opiate? Someone calls for opiates, or how approach to a substance abuse patient? It's up to you.
No, let's have you a substance abuse, because you did mention, and like you said, most people coming in now, it's polysubstance. Yeah. They're on coke or stimulant and a opioid. So let's see how you approach that. How you would tackle that.
I'm going to try to give you a kind of a general. All-encompassing answer, because I should be able to do that because our practice is so individualized. But in general, the way it is done is there's levels of treatment for depending the intensity and frequency of your use and abuse. Someone's regularly using heroin, it's called, within the clinical criteria, detox. You go into a detox. Then there's a step down to what's called a partial hospitalization, then intensive outpatient treatment and out treatment. For the most part, and I'm not going to comment on that's wrong or right, but the numbers aren't happening. You don't have to necessarily go by that criteria because not only does it not work, but not everybody needs that intensity of care, which doesn't work anyway, right? What they need, you have to look at the individual, you have to look at their resources, and you have to look at where they're at in their desire to come in and see you. That's before you even evaluate the substances. Who are you? Why are you coming in here? What resources do you have to stop? And that's an important question in a society like ours. That's how the political economy is set up. People have to have insurance pay for. Okay. After I realized that, so for example, if my girlfriend's going to leave me unless if I go quit heroin, you're a very different patient than someone who has just gotten out of jail for the 7th time, has abscesses, HIV, hepatitis C, and is 10 years older than that first patient. Nevertheless, the way we approach it is everybody should come in, right? And we don't care if you're using or not using. 2, you're going to see people and you eventually start to tease out that, look, everyone's using everything at the same time, right? I don't even know what somebody like that would go into a detox for, because they don't know what to do. What are they going to do? Ask the insurance for 4 days of heroin, 4 days of alcohol, 4 days of coke? No, the way we do it is really simple. We're a medical office. They come in. You're doing meth. You're doing benzodiazepines. You're doing fentanyl that you're buying on the street. We look at you where you're at. We give our treatment recommendation. We are a full advocate of medication-assisted treatment for most people, because the data tells us that will get you to where you need to go. And the medication-assisted treatment refers to buprenorphine products, Suboxone products for heroin addiction, opiate addiction. It's one of the few drug addictions that we actually have a medication that works, regardless of what you hear out there.
Well, I want to hear how that works. I forgot to ask, there was a couple questions. You don't like the word detox. A lot of people throw that word around, and I want you to explain why. You have a better term for it. And also, when somebody relapses, you have better terminology. So let's hear your reasoning, why what you use instead of the word detox, and why.
Sure. People talk about, hey, you need to detox. It's in the cultural vernacular, but detox also has a more technical name, and that is a kind of a designation given by level of treatment by the insurance companies and substance abuse and mental health treatment and all that stuff like that. It's when you go right into the initial first few days of coming off drugs. number one, and if you look at videos from years ago, I was advocating for getting rid of that term. Like a couple of years ago, I believe, the substance abuse and mental health started to use a different term. Detox, the way it's used, and you watch it on the TV shows, it implies some sort of a beginning and end, right? Is the issue, let's just take heroin. Is the issue getting the heroin out of your system? Is that what you mean by detox? So what? That doesn't make you any less of an addict than if you have your system full of heroin. What does detox mean, and what does it do for the disease of addiction? Nothing. It's an initial stage of something that is chronic, relapsing, remitting, and you need to redefine the clinical outcome you're looking at. Once you do that, you will redefine success. Once you do that, you lend that concept to the addict, empower them, destigmatize the issues such as relapses and so forth, and you will be heading on your way for what should be recovery. Detox is really basically medically supervised withdrawals. And as I said, you don't really need medical supervision except if it's alcohol, benzos, or barbiturates. It's painful, and I'll take the pain away. But it's not. I could put you in a jail cell and watch you detox for 5 days. I let you out. You're going to go use. The term itself, the way it's been used, the way promoted on media, and the way the practitioners and treatment centers have used it has never produced any positive outcomes. It's medically facilitated initial withdrawals.
All right, let's talk about like the withdrawal timeline and acute and chronic, and how you're going to tackle that. Like, how long should people expect for when they're first getting off of the opiates? Or you talk about the difference between the acute phase, chronic phase, and then there's a show on television called Dope Sick. If you could explain that term and what that means with respect to withdrawal.
I mean, acute withdrawal, again, give or take, plus or minus, and fentanyls have added a new twist to it, in addition to the fact that people aren't realizing they're mixing their drugs, so withdrawals are slightly off the usual timelines, but a couple of weeks is what they usually define as acute withdrawals, right? First day or so, you'll see the person severely sweating, nausea, vomiting, body aches, sleeplessness, restlessness, anxiety,
Would it be
insomnia.
like the worst flu they've ever had?
Yeah, and somebody, once I said that, then not a patient, but a user got extremely offended. They're like, dude, you're going to call this a flu? I was like, sorry.
But, most people have had the flu, and I've been told, and think of it as the worst flu that you've ever had in your life, where you're flat on your back, you can't get up.
Yeah, but I'm just saying, that's
and every day feels like that when you're withdrawing.
Yeah, and so, those are a couple of weeks, and there's this thing that's called PAWS, post-acute withdrawal syndrome. And for people, it's a little bit mysterious, and it's the psychological long-term withdrawals that goes on for months. This is where I have, number one, during the initial withdrawal stage, the acute withdrawal is a high risk relapse time, right? Because it sucks coming off of this drug. Your body's screaming, get me back to my normal homeostatic baseline. I need those receptors filled. I think where people miss the point is in PAWS, post-acute withdrawal syndrome, which is long-term withdrawals. 4 months later, 5 months later, 6 months later, 7 months later. In fact, a study back in the 70s looked and saw that there was basic physiological things that they were measuring: heart rate, blood pressure, cortisol level. These things were still elevated 7 months out, which really means 7 months out, this person was still going through withdrawals. That being said, so many relapses happened during that time, and all of this can be mitigated if people were put on medication-assisted replacement treatment. And over the years, I have really been able to see this. With some of the people, they're just white-knuckling it and pretending, right? It's 4 months out. You know, they have this white plastic smile on their face and they're extremely rigid. They've sort of gotten into this recovery community, which they traded one subculture for another, right? If you see it, especially in Orange County, everyone has to go to the gym, everyone has to wear a certain hat. It's really silly. But you start to unmask the underlying anxiety, the underlying depression, the underlying lack of self-worth, meaning, and how to cope with the world. And they still, and this might seem a little controversial to American public, they also need to be reevaluated and put on replacement medication, which was traditionally methadone, and now we also have buprenorphine products.
Oh, okay. Could you talk about how methadone and buprenorphine are working? What's the mechanism of action, or so people, people can understand what they're doing?
Sure.
And then also there was one, another term from watching your videos that I saw that you think if there's a better term is when people think of relapse. I'd love you to you have a better definition. So
yeah, that's important, and that's another one. If you look years back, I was making videos saying, please stop calling this relapse. Again, I think it's SAMHSA, you know, mental health, substance abuse and mental health. They're like, hey, please stop using that. They had a whole publication on the changing of these terminology, and we were talking about it years ago. So, and I saw this working a little bit in the treatment industry. Let's say Joe X has been clean for 8 months, and they're using and I'm not knocking down the 12-step traditions, but 12-step tradition, day 1, day 2, day 3, day 4, whatever. And now he's got his own apartment, now he's got a girlfriend, now he's got a job, he's going to work. One night his girlfriend cheats on him, leaves him, gets fired from his job, whatever. All right, that one night he takes a whole bunch of pills, okay, and he's not. That's not a relapse. And what was happening, to what I could see kind of sort of anecdotally, certainly I haven't done a study on this, was that, all right, he relapsed, let's put him back in treatment, bang the insurance companies $3,000 a day for detox. You just destroyed this guy's life. He's got a job, he's got an apartment. His sense of self-worth just went down the tube for 1 day of use. That's an episode of use. Continued episode of use will lead to a relapse. The patient or the client needs to understand certain things. You've been clean for 9 months. Do you know what that means? No, you didn't throw everything away. You didn't relapse. You've been clean 9 months. That means for the last 9 months, your neural networks have been learning to cope with reality without the use of a substance. No one can take that away from you. You use tonight, take all the tools and resources you have from the last 9 months, get up in the morning, let's do this again. That's how it should be approached. The science tells you that, and human psyche tells you that. And that will empower the patient, and you don't want to judge them during those times. We don't fire people, we don't do anything, right? At our clinic, and I don't know what other people do. You want to explain that to them, make them understand, pat them on the back, and tell them, let's move forward.
All right, love that. Thank you for clarifying. You mentioned the two medicines, methadone and the buprenorphine, and talk about how those are used and what's happening with those medicines.
Sure. Just so you know, the kind of the standard perspective now, even in some of the publications, they consider naltrexone as a medication-assisted treatment. It's not. But in terms of methadone and Suboxone, incidentally, those are both synthetic opiates. Remember, we made definition. Morphine is a real thing, right? Heroin is semi-synthetic. Fentanyl is synthetic. So is methadone. So is Suboxone. Right? They have different mechanisms, actually. So the property of both of them that they share that makes them fantastic for replacement medication is the way they act. One of the properties, I'm trying to get a property that they both share, is the fact that they don't have the up and down. They steady stay in your system long term, and that decreases abuse potential, right? But here's something else. Methadone has a euphoric effect, what I call a supratentorial effect. Buprenorphine products really don't, because of certain receptor properties that they have, okay? So one, they're long-term throughout the day. Two, something like buprenorphine, if I took it, yeah, I would get a rush. But a daily user isn't going to get a rush after you titrate the dose. And what it does is it takes care of the cravings, right? And it takes care of the withdrawals, and really allows the rest of your central nervous system to heal, right? And it's a great pain medication. And so, people always sit there and discuss, oh my God, he's on too much Suboxone, right? At 20 milligrams, 24 milligrams. Okay, the international standard data shows us 16 to 24 milligrams is the average dose. The way you should dose it is to cravings and withdrawals, not keeping it as low as possible. Now you're keeping him in a constant state of craving and withdrawal, and stigmatizing the medication, which the only place on the planet that does is the United States. France, they hand this stuff out like water, and in Portugal, same thing. And so the way these work is they replace the opiates, to simplify, they replace the receptor from the heroin and all that stuff, and ideally they last longer. You don't need an escalating dose to get the same level of coverage, right? And certainly in the case of buprenorphine, it has a ceiling effect where you can't really overdose on it. You can under extreme circumstances. So it's safe, and you can stay on that dose for a long time and go about your business like any medication. I'm oversimplifying it, but that's basically what they...
Well, if you get too technical, people tune out. It's like too much.
Yeah, I mean, there's other properties to it, but basically it's meant to replace the opiates, get rid of the cravings, get rid of the withdrawal, and let you go about your day. That's the simplest way to describe these medications.
Okay.